Welcome everybody to ICMDA webinars for this week. I'm Dr. Peter Saunders, the CEO of the International Christian Medical and Dental Association, which brings together Christian medical and dental groups in over 80 countries worldwide. And our aim is to start and strengthen national Christian medical and dental movements. Well, we're focusing on the D in ICMDA today, dentistry, and we're greatly privileged to have Professor Raman Bedi talking to us about COVID-19, a dental perspective. Professor Raman Bedi is chairman of the Global Child Dental Health Fund and emeritus professor of King's College London. He was some time ago the chief dental officer for England from October 2002 to October 2005. He was awarded a Doctor of Science by the University of Bristol in 2003 to his contribution to dental research, and a Doctor of Humane Letters in 2010 at A.T. Still University, Arizona, for his contribution to the social sciences. He's published over 210 scientific papers, and since 2012 he's chaired the World Federation of Public Health Associations Oral Health Working Group. In the past, he's also been president of the British Society for Disability and Oral Health, president of the Education Research Group, the IADR, and chair of the IADR Regional Development Programme Committee. So it's my pleasure to introduce Professor Raman Bedi to speak to us on COVID-19, a dental perspective. Thank you.
Peter, thank you very much. And it's really a privilege to be here. So thank you all for sparing some time to listen to this talk. I was asked to speak on COVID-19, a dental perspective. Next slide, please. So I have to say thank you, first of all, again to ICMDA and of course the Christian Dental Fellowship in the UK, of which I've been a member since I was a dental student. This is very much a personal perspective, and although dentistry is a broad subject area, I'm going to focus on primary dental care with a particular focus on the UK. I'm going to give you a little bit about my activities, which are mainly involved in a leadership program around the world. And the reason I'm doing that is because if there's one thing we need in oral health and dentistry today, is that we need our leaders to step up and to work collaboratively together, because some of the challenges are really significant. Then I'm going to cover the SARS-CoV-2 and clinical dentistry and the challenges, and then the implications this has on the business of dentistry. And a lot of dentistry is in primary care and run as independent businesses. And then end with two major opportunities and of course the threats that we have. Next slide, please. For the past 14 years, I've been running a leadership program for senior dentists. It's called the Senior Dental Leadership Program, and this was last year's cohort. There you will see the CEO of the largest dental corporate in China, the chief dental officers from Albania, England, the head of the dental regulatory organization in the Philippines. You've seen deans from Cambodia, from Tanzania, and from Australia, as well as the Vice Chancellor of a medical school in Ethiopia. Next slide, please. So the reason why we dedicate so much time and energy into our leadership program is because dentistry is a very fragmented subject area. And we need our senior dental leaders to come together and to work together, and also to step up with leadership skills. Next slide, please. So the SDL program brings together a really powerful collaboration. Harvard University, King's College London, Henry Schein, which is the largest dental retailer in the world, and Colgate-Palmolive, a global consumer company. And these four organizations are not just sponsors, but they get involved. So at each meeting, the Dean of Harvard and King's attend, the Chairman and the CEO of Henry Schein is there, and the Vice President of Colgate. So it's more than just supporting the program, it's actually being involved. Next slide, please. So over the last 14 years, we've had 200 delegates over 46 countries, and all becoming part of an important alumni. Next slide, please. The reason why I want to focus on leadership is because if there's one thing that we need now is our dental leaders to work collaboratively together. What I notice more and more is the fragmentation of each country doing their own things and a lack of coordination that we need. And we also need our leaders to have the ability to take the issues of dentistry to health ministers and governments, and to be able to explain the unique nature of dentistry and its challenges. Next slide, please. What I'm not going to cover is oral health and the challenges which are well documented well before COVID pandemic was announced. The WHO estimate over 530 million children have untreated dental decay in their primary teeth, or cancers increasing, and of course inequalities were significant and will become more significant as a result of the pandemic. Next slide, please. So what are the challenges to dentistry and dentists? Well, the difficulty is that dental teams work very close to patient faces, and for prolonged periods of time. They're exposed to saliva and blood, and the chances of infection for the dental staff is high. And not only that, of passing the infection to patients. Dentistry is being classified as one of the most high-risk areas for infection. Next slide, please. There are three main challenges in the dental surgery. There's the direct transmission through inhalation of droplets generated by coughing or sneezing. And of course, as the droplets remain in the air, there's an exposure to the mucous membrane of the eye, nose, and oral mucosa of the patient in the chair. And then, of course, as the next patient comes in, the exposure to them of droplets that remain in the environment. There's also the indirect transmission of contaminated surfaces. Next slide, please. So this is the challenge we have in dentistry and why it makes dentistry such a high-risk area. We all know that social distancing, because droplets remain in the air and are projected over a distance. The difficulty with this droplet transmission is that dentists need to use aerosols, generating procedures to do most of dentistry. So every time a dentist puts a high-speed drill with water splashing, there's aerosols being created. So most of our dental procedures are aerosol generating procedures, or we say AGP. The difficulty we have is how do we mitigate and resolve those issues when we're providing dental care. Next slide, please. So for a while since the pandemic, even before dentistry was brought back into service, we were doing remote consultations, basically usually on telephones or Zoom, and we were giving advice, analgesics, and antimicrobials. Governments were promoting good oral hygiene and self-care, through social media and the mass media. And we set up a series of urgent dental centers. This is still being undertaken in a number of countries. And for the last month or last 6 weeks, dentistry is going back to its usual provision of service, but with a difference. Now we're screening patients and triaging patients. We're making sure that the timetable and scheduling of patients is sufficient so that there aren't people waiting in waiting rooms. Obviously, social distancing within the practice and PPE. But what we've had to do is that we've had to increase the ventilation in the practices and high vacuum extractors. And these below are just some of the equipment that is now on the market. All these have increased significant costs to dental practices in providing this type of care. But the thing that really has made dentistry economically challenging is this fallow time. Remember I said that we had the difficulty of aerosols in the environment for a period of time. And now, so dentists have to wait between patients a period of time to allow not only the cleaning of surfaces, but the environment to reduce the aerosol contamination in the air. So in my practice that I work in, we would normally see about 15 patients a day. Now we're seeing 6. Of course, all this adds to the cost. Next slide, please. So the challenges we have in dentistry are the economics. Already we're seeing in a number of countries, dental businesses be going into bankruptcy. Dentists not being able to open because of the costs involved to the providers. Patients are also reluctant to attend. It's difficult in many countries to get PPE. I was in contact with a number of mission hospitals in Africa, and of course they are reliant on patient charges. And so they don't have the luxury of furlough schemes or government supported the salaries. And so these mission hospitals and other hospitals are stretched in keeping their staff when there are very few patients. Training institutions, dental schools are finding challenges because many of them are designed with open surgeries, and with aerosol generating procedures, they prove a particular challenge. Dental schools also in a number of countries rely on postgraduate income, and that too is dwindling as there is a reluctance of people to travel and internationally, and of course it's very difficult to provide clinical training when there are so many restrictions on providing care. The result of dentistry has led to some high levels of early retirements of dentistry, and we will see workforce shortages in many countries. The reason why I put etc., etc., etc. is that all these are adding up to an unsustainable situation in dentistry, which there is no easy answer to resolve. So a number of countries are beginning to go back to providing dental care with some restrictions, not all the restrictions I've outlined, and others are being more slow in returning to normal dentistry. And that has led to real difficulties, which are only now being resolved. Next slide, please. So in the UK, dentistry in the last month was beginning to come back to some degree of normality. Although restricted with extra costs, although actually having to see fewer patients, there was a return to normal dentistry, and this is seen in a number of countries across Europe and in North America. And then last week, we all received this document from the WHO. And this interim guidance was released on the 3rd of August, but only actually hit most of our desks this week. And yesterday, it was on the newspapers of the Daily Mail, the New York Times, etc., which said the WHO are recommending that you do not go to see a dentist. So dental practices and social media today and yesterday have been saying patients are cancelling appointments. But what did the WHO actually say? They said that the definition of aerosol generating procedures is as follows. Obviously the triple syringe, anything that generates water, high-speed drills, polishing, cementing crowns, and dental implants. Those we knew, but they added 2 extra. Restorations, direct or indirect. Now, in many low-income countries, the only dental procedures that they do is to hand excavate the dental decay in a cavity and place in there a glass enamel restorations called the ART, the atraumatic restorative technique. And of course, they do extractions. Traditionally, we did not see these as aerosol generating procedures. But as from this week, from the WHO, the guidance is that even those 2 procedures should be avoided. The WHO now have formally stated that routine, non-essential oral health care should be delayed until there is a sufficient reduction in COVID-19. The difficulty of that is that it's difficult to interpret what that reduction means and whether in any area where there is restricted policies that should be implemented. Of course, the WHO is advisory and it advises governments. So each government in itself will advise the procedures for that country. But clearly this interim guidance has reached the media and has now made the procedure of dentistry very unclear. Now, I don't want to paint too dark a picture, but the challenges facing dentistry are significant, and I think more significant than many other areas in healthcare. Dentistry is split up into small dental practices which run independently and are small businesses. And the challenge that I've outlined has placed them under severe pressure, and the uncertainty of the WHO guidance has also increased that. But there are real opportunities as well. The handbrake has been placed on dentistry and dental care, and we've all had to stop, and it's an opportunity to rethink and realign ourselves as to what type of improvements the new norm may appear like. There are 2 things I've highlighted which we've been working as a charity on. The first, we have been talking for many years the importance of integrating dentistry and coming closer to medicine, the integration of oral and medical care. We have an opportunity now with these new restrictions, with this redesigning of our dental services, to take integration much more seriously. The second is that prevention should now be given a much higher priority, and certainly some of the newer methods of prevention should be implemented, particularly those that do not involve aerosol generation. I'm going to end by showing you 2 small videos that we have produced following a major conference about integration. The first one is based on a declaration which we launched in Taiwan, and it's the Taiwan Declaration. Josh, if you could play the first slide, please, the first video.
The Taiwan Declaration on the Integration of Oral and General Health was launched in 2019. It was a milestone in global health, making integration a reality. The declaration called for recognition of 6 key facts about oral health, highlighting the shared risk factors of poor oral and general health and the mutual benefits of integration. The declaration also included 6 priority action areas to facilitate integration. For example, applying a health and oral health in all policies approach. 3 short-term activities were proposed: advocacy, thought leadership, and fostering tailored implementation. These activities have stimulated a number of countries to develop interventions to integrate oral health into general health. Dr. Shu Ti-Chiu's numerous projects have highlighted how funding from the Taiwanese sin tax from cigarette sales can be used to cover the costs of this integration. The Taiwan Declaration on the Integration of Oral and General Health is an excellent working example of a national strategy to embed health and oral health in all policies to promote good oral and general health. Dr. Bruce Donoff, a pioneer of the integration of dental and oral health in the USA, states that the combined teaching of dental and medical students is significantly effective in the integration of oral health into general healthcare. Dr. Donoff highlights the importance of the Lancet series titled Oral Health, which pointed to integration as a solution to the global oral health crisis. Research by Professor Mahesh Verma shows that diabetes, cardiovascular disease, and poor oral health are the leading causes of mortality in India, and integrating oral and general health could achieve improvements in non-communicable disease rates. Dr. Mengistu Asnaki's work highlighted that multitasking and transferable skills are essential in low-income countries. His research shows that this is often the only solution in rural areas due to limited resources and low workforce numbers. This is demonstrated in the Community Health Extension Programme in Ethiopia, which is a great case study for how political action and community engagement can aid in the integration of dental care into general healthcare in a low-income country. Based on the feasibility of the interventions across the world, Dr. Borish advocated for a new dialogue between global agencies and governments to make sure integration became a reality everywhere. She highlighted how it could empower overall health promotion, prevent the increase of oral diseases, and boost health equity. It's not only advisable, but is critical, and it's important for everyone.
Thank you, Josh. So I started this talk talking about the importance of leadership and how leadership is vital for public health. The challenges we've had with in dentistry are significant. There is no easy solution. We have not worked out how we can deal with the aerosol generating procedures, and the business of dentistry is under threat. I believe that it will be inevitable that financial support will have to be provided by governments to dentistry. The reason I wanted to raise the issue of integration is that we should insist that any financial support should embrace a complete rethinking of how we provide dentistry and how we can integrate dental and medical care closer together in a way that we have not done in the past. So I believe there is some really significant opportunities now to be able to reshape something that we all know would be the best for patients, is a far better integration. The second thing I think should be conditional on any support that is made by governments is the focus on prevention and all the new types of prevention that is out there. Dentistry has for far too often been treatment orientated. And now we have an opportunity to reshape and rethink how we provide care and how we stimulate a new preventive approach. And I'm going to end with a short video that will actually highlight that from another major conference that I was chairing last year. Josh, if you could play the last video, please.
The consumption of free sugars and processed carbohydrates has increased around the globe in developed and developing countries alike. Lower income groups are particularly vulnerable to high dietary intake, and this has created a disparity in caries experience across socio-economic groups. This inequality has created a global challenge for oral health professionals, and so far, few initiatives have successfully managed to address it effectively. In many parts of the world, young children don't go to the dentist. This can be extremely problematic because when caries go untreated, our research shows that affected children can suffer from pain and decreased quality of life. Treatment costs can be high, which puts pressure on families, and this is especially prevalent in those belonging to low-income groups. Silver diamine fluoride, or SDF, is a promising new approach to improving child dental care that we argue should be implemented globally. SDF is a clear liquid that combines the antibacterial effects of silver and the remineralizing effects of fluoride. Numerous studies support the efficacy of SDF for caries in children's teeth and in the prevention of new root caries lesions. SDF should be used in all dental practices to prevent child dental pain and the need for general anaesthetic. Dr. Richard Naderman found that using SDF in community programs can reduce inequality in oral health among children. The same study also showed that SDF delivers a better cost-benefit ratio than traditional oral health care. Dr. Prathit Phantom Vanit showed that a technique called Silver ART, which is the use of SDF in atraumatic restorative treatment, could improve treatment outcomes when compared to ART restoration, again supporting the use of SDF in dental practice. Professor Chung-Hung Chu investigated the impact of SDF use in young children and found it could significantly reduce the incidence of new cavities in kindergarten children. The study was so successful that SDF has now been implemented in community treatment programs across Hong Kong. Other countries must follow suit. And Melbourne-based Dr. Jeff Knight demonstrated that SDF usage results in a significant reduction in invasive dental treatments and general anaesthetic, as well as in pain and sepsis. SDF is safe, effective and efficient, and is transforming the community approach of dental care for children. SDF could also increase community support and engagement by helping to reduce dental issues for children whose parents have not traditionally seen dental practitioners. This is why we advocate for the inclusion of SDF in outreach dental programs globally, especially for young children.
Thank you very much. What I want to end by highlighting is that this is a great opportunity for dentistry. We're facing, as many other businesses, from the airline industry to the hospitality industry, real challenges which are not easily resolved. The aerosol generating procedures will not easily be resolved. And the challenges we have in dentistry is that we can reshape and rethink through many of the challenges that we have not paid sufficient attention to. And I've highlighted the two, which is integration and innovative prevention. Much more investment needs to go into prevention, and we need to be promoting that. Leadership will help us do that. And that, I think, is the opportunities we have in this pandemic, is that this has enabled us to begin to rethink and to challenge ourselves. So I want to thank everyone very much for giving me this opportunity, and I'll hand now back to Peter.
Thank you very much indeed. We've been listening to Professor Raman Bedi addressing the question of COVID-19, a dental perspective, and we've got a time of Q&A now. So if you have questions you'd like me to put to Professor Bedi, you can type those into the Q&A box at the bottom of your screen, and you can upvote questions that other people have asked, which will make it more likely for them to be asked during the limited time that we have. Some people have been putting questions into the chat box. If that's you, then please retype them into the Q&A box so that we don't miss them when they come. If you've joined the presentation part way through, then you may not know that this is also available in French, Spanish, Portuguese, and Mandarin Chinese. And if you click the interpretations icon, the globe on the bottom of your screen, you can choose which language you'd like to hear the question and answer in. So we've had a masterful presentation. Thank you very much, Professor Bedi, for underlying and modeling too the importance of leadership going forward, and the particular challenges that dentistry faces, especially because of the close relation between dentist and patient and the use of aerosol procedures. And for those two very practical ways forward, the integration of dental and oral care, and then secondly, making prevention a much greater priority globally, worldwide. So let's move into the questions now. The first question here is, what's your opinion about opening dental schools? And if so, what are the best guidelines to follow?
So thank you very much, Peter. Dental schools have challenges with, as all universities do. So most dental schools are based within a university, and many of our universities here in Europe are doing remote education. Now, there is only so much we can teach in remote education when you have clinical skills to be taught. So the challenges that dental schools are going to face is, how can they teach the clinical skills when it's going to be very difficult with the design of many dental schools with open clinics, a large number of students in a limited space, and also getting patients to attend. So they're going to be facing a lot of challenges to do that, but I'm sure that there are solutions to be found.
Thank you. The next question is, how can we integrate faith into dental practice? Because dentistry is largely privately funded, and with the move into dental spas and dental studios, can you give us some guidance on that? I've always thought that dental patients are a captive audience in a sense, because their mouths are filled with instruments and they have no opportunity to reply. But how do we integrate faith into dental practice?
Well, I think into dentistry generally. So I'll just give the example of the Christian Dental Fellowship in the UK. So first of all, within dental practice, how can we help Christian dentists working? That's the first thing. And the Christian Dental Fellowship here has been running regular prayer meetings. It's been providing counselling for any member of the dental team because of the stress or mental health issues, to be able to support them. And then, of course, the providing training and literature for about the Christian Dental Fellowship that dentists can give to their patients. Now, of course, when you're actually providing dental care to patients, many of us make it quite clear that we're Christians and that we have a Christian faith. So in that sense, it's important way to witness. The ethics, I think all dentists sign up, whether they're Christians or not, to a standard of ethics and behavior and appropriate care. And I think that's the same, should be the same for everyone, irrespective of whether they're from a faith or belief or not. I'm not sure how I could answer the question when it was raised as how you would integrate the different faiths together. I think I'd need some reflection on that, because I'm not quite sure how that could happen in a meaningful way.
Now, there are lots of dentists in ICMDA. We've got a global network of Christian dentists. What role do you think that ICMDA and the members of our national organizations can play in dental leadership, as you've been outlining it? What should be our unique contribution as Christians compared to other global dental leaders?
So there's a certain group of leaders, and thank you for the question, but there's a certain group of dental leaders who are in leadership positions, and they're the people that I work with, chief dental officers, presidents of dental associations. These individuals have direct access to governments, health ministers, and can discuss policy terms. I think ICMDA at the level of supporting Christian dentists and other dentists, we're seeing, I think, some significant mental health issues and pressures on dentistry. People really concerned about loss of income, loss of their businesses, not knowing how they should react to some of the guidelines and difficulties being challenged. These are real pressures on different members of the dental team. I think ICMDA and National Christian Dental Fellowship organizations have a real responsibility here to reach out and support members, particularly Christian dentists, but also all dentists who are seeking help and guidance.
Thank you. Next question relates to Developing World Mission. What dental mission programs are available for dental students and young dentists around the world? So a lot of those listening will be actually students in dentistry and thinking about serving in a global context.
It does. So traditionally, many of our dental charities, including the Global Child Dental Fund, we have volunteers who want to go and help in different settings. And also dental electives. Many people go on dental electives in their final year overseas to a low-income country. The difficulties we have now is that creates a real uncertainty. International travel is difficult, and the planning of individuals going into different countries with restrictions in visas and restrictions in entry have made this all really very, very difficult. But if you can't manage to make a contribution or help in physically by traveling, restrictions, there are more innovative ways that we can help. I think what we've been trying to do in Zambia and in Kenya is to link people up via WhatsApp groups or through distant communication so that people can support each other through education, training, just sharing experiences. So we can do things virtually, but I do believe that for the foreseeable future, the international travel, the traditional dental electives will not happen.
Okay. Are there any opportunities for international collaborations between CDF UK, CMDA, US Dental, and other dental bodies throughout the world? And if so, what would this look like?
There is a real collaboration, and I think we should start discussing it. Dentistry is at a crossroads. It's in a real crossroads because the future is unknown. We're having to rethink a lot of issues around how we provide care and the type of dentistry or the dental profession that we actually want. I do believe there is a Christian voice that needs to be expressed there. And that could be an international collaborative voice, being able to articulate the importance of prevention, the importance of supporting how we support members of the dental profession, and those type of things that should happen. And then we should look at some of the things that we're doing here with the Christian Dental Fellowship in the UK about being able to support other members of the profession through mental health, counselling, being an opportunity. These are things that we should be able to do collaboratively across national borders.
Thank you. You made you finished your presentation before the videos, putting up that, in many ways, quite extraordinary statement from the WHO about direct and indirect restorations and extractions being part of aerosol generating procedures. And can you tell us what was the rationale of the WHO in including those, and has it been challenged? Is it challengeable and reviewable?
Well, I think as we all know, the WHO have just released those interim guidance, and it's advisory. So the WHO doesn't have executive functions. They just advise national governments on some policies. So it will be up for each country to decide. I'm not sure the rationale and how they arrived at that, but by including extractions and direct and indirect respirations, they've made it very difficult for many low-income countries, because many low-income countries do not have or cannot afford usually PPE and the necessary protection for the staffs. On a personal level, this is just a personal perspective, I think that extractions could be undertaken safely with and are not aerosol generating. So obviously some degree of protection that we should be instilling. And I also believe that the ART, the traditional just excavation of caries with a hand instrument and placing of a glass ionomer, these things should be allowed, and we should be looking at some type of guidance to the dental professionals, particularly in low-income countries. For example, to take a pre-treatment mouthwash to make sure that people do have gloves and single-use instruments, making sure there is as much social distancing that can be happening. But I do personally, on a personal level, think it was unfortunate that that should have been included in an aerosol generating procedure list.
Has the guidance been challenged yet, or is it just such early days with it only coming out that people haven't had a chance to react?
Well, there have been some reaction, but people have not, there have been no formal policies I'm aware of. This only actually reached the media on Tuesday. So this was only a few days old. So we've only been all aware of it over the last few days. I'm sure there will be lots of further discussions with regard to this.
Now, the second video you showed talked about prevention and particularly the role of SDF and recommending its much wider use. There's a comment here from someone in the Philippines to say that they've been using SDF in the Philippines through the program of the Philippine Pediatric Dental Society. There's no question, but I wonder if I can ask you a question off the back of that about how crucial SDF is and how widely it's being used at the moment, and what are the challenges to its further use?
Well, it's increasingly becoming more widely. So in England, it became part of some statements made by the Department of Health as the things that we should be looking at. But it's not just SDF. I don't want to sort of say SDF is the only thing, but there's quite a number of innovation preventive products that should actually be promoted, and we should be developing further, more and more. Prevention. The dental disease is largely preventable, and the fact is that our focus has been very much on treatment, and now we have a real opportunity to begin to reorientate ourselves into a preventive mode. And it should, I personally believe, should be a requirement of any funding that any government give to the dental profession or support. It should be a requirement that a far more preventive orientated dental care system is embraced.
Thank you. We're listening to Professor Bedi on COVID-19, a dental perspective. Keep the questions coming in. You can type them into the Q&A box along the bottom, not the chat box, the Q&A box. So if you put your questions into chat, please retype them into Q&A. And if there are questions you particularly would like to hear asked, then you can upvote them in the Q&A box. So it's a question here about the use of PPE and especially one patient, one PPE policies. And the impact of that on the environment and the balancing of risks. Is that what, could you tackle that one?
Okay, so there's obviously quite a lot of discussion about the levels of the PPE that is required. So I'll just go into what I do and what is the policy of the clinical practice I work in. We have all patients who are on non-aerosol generating procedures. In other words, examinations, fluoride varnish prevention. We have the usual procedures of obviously triaging patients, social distancing, checking temperatures, etc. But when they come into the surgery, we wear a gown and a normal face mask, an FP1. And that's the procedures that we actually proceed. If we actually do an aerosol generating procedure, we have that restricted to a dedicated clinic where there is a full FP3 mask is worn. We change gowns after every patient, and we change masks. Now, I'm not saying that's a very expensive approach for many clinicians and many different parts of the world, but that's currently what we do. We do change the full PPE between patients.
Thank you. Another question on another clinical question on surgery setup. Would you please comment on the effectiveness of UVC lights in dentistry, and also the use of 1-minute mouth rinses pre-dental work using hydrogen peroxide or dilute 1% povidone? The latter is much more easily available in resource-poor countries.
It can. So a pre-treatment mouthwash is always advisable. It reduces the viral burden. So yes, hydrogen peroxide and also chlorhexidine, which we use and I like to use to that the patients are often used to it themselves. So that should be standard procedure. I always sort of try and put reservations because in low-income countries, some of these things are not available. But if affordable and available, yes, that should be undertaken. The mitigation of the environment, the aerosol, there have been two major approaches that are taken. One is obviously UV light, and I think the research behind that is growing, but is still limited. And the other is through extractor fans, large extractor fans, which I showed that are around where the air is brought in through a filter that obviously then will make claims that they can reduce the viral load in the environment. In both those issues, I think the research is growing, but it's still limited. But there's been a large amount of investment that dentists have made. Many of the extractor fans that are happening are in the region of 1,000 to 1,500 sterling pounds. And there is the UV lights are relatively expensive as well. But we are all trying very hard to work out a system that will allow us to mitigate against the aerosol that's been generated. At the moment, we haven't found the solution, but there are some that will help us reduce the viral load a little. So I'm not a great believer in the UV. We haven't invested that, but we have invested in the extractor fans and the filters resulting from them.
Thank you. Please keep your questions coming in the Q&A box down below. If you put them into chat, please retype them into Q&A. So another question here about sharing faith in a dental context. What do you think there are opportunities, and if so, how are those opportunities best made use of in the dental clinic? Many of our listeners will be familiar with the Saline Process program, which tells people how to share faith with sensitivity, permission, and respect in dental and medical practice. Are there opportunities, and what are the best ways of taking use of them?
There are opportunities. I've always found it quite challenging in the clinical setting because patients actually come, they want to have some treatment or some engagements. But there are indirect methods so you can make your faith known. For example, most dental practices have a website, and on that website, there can be clear indications of charities or Christian organizations that the practice support and the reason why. So that's a very good way of showing social responsibility and care. There's also leaflets in the practice that you can actually have that patients can pick up and then realize the type of ethos and the practice has. So yes, I think there are many ways you can make your Christian faith known in practice, but I have directly talking to the patients unless they ask and witnessing is challenging. And I'm really pleased about the saline process that you outlined, Peter, which was really helpful.
You've stressed a lot the importance of leadership, and your own role very much underlines that as a huge priority for you at the present time. Overall, what do leaders need to do in order to fight this pandemic efficiently? What does good dental leadership look like with the COVID pandemic?
I think good dental leadership is, first of all, is two things. One is internal and one's external. So internally, people working in a senior leadership program need to explain to health ministers, treasuries, etc., the challenges that face dentistry. It's not straightforward, it's not obvious, the challenges that dentistry face and the difficulties that need to be addressed. And the support they need, the financial support and other support that they actually need to have. Leaders then also need to be externally facing. They need to face, first of all, the profession, to explain to them what needs to be done and how to work collectively together. There needs to be a coming together of the profession to begin to address some of the changes. And then, of course, the leaders also need to be the spokesman and the authoritative voice to the public to reassure them about safety and about the procedures that are being put into place.
Thank you. We're just about out of time now. There's one last question here. I'm the chief of dental practice at a university in the Honduras. I'm interested in establishing dental collaboration with other universities and learning how to implement Christian collaborations. What can I do?
Sandra, that's really interesting question, and thank you for that. I have spent the last, since leaving the Department of Health and the Chief Dental Officer post, trying to build collaborations with senior dentists. But I also believe that Christian dentists in senior positions could actually begin to reach out and work collaboratively internationally. And that was one of the reasons I was so delighted to come and be invited to the ICMDA, because I think they play a very significant role in allowing that collaboration to happen, and so that we can begin to discuss it, so that we can really enter into a meaningful international Christian network.
Thank you. And if you've joined us partway through, then you may not have heard that the ICMDA, the International Christian Medical and Dental Association, brings together over 80 national groups around the world of Christian doctors and dentists. Most of these groups are both doctors and dentists. So one of the best ways, as has just been outlined, is to get in touch with your national body, or if there isn't one, to get people together and form one. And then through the ICMDA network, we can link you up with dentists in other countries, or people who can give you opportunities and experience. In fact, a number of our field workers are practicing dentists. And I know the Hedwin Cadrianto, who's on this call, because he's been busy as ever in the chat box. I'm sure he would, he's probably one of the best networked Christian dentists, certainly in Southeast Asia and probably around the world, and he would be only too happy to help you there, and so would we at Central Office. So you can get us through office@icmda.net. So thank you very much for listening to us. Thank you so much, Professor Raman Bedi, for that incredibly illuminating talk and for handling all the questions that people have come up with. If you've missed some of this talk or know others who'd like to hear it, then, well, I can tell you that it has been recorded and it will go up on our ICMDA YouTube channel, accessible through the website at icmda.net in the next 24 hours or so. And then if you booked for this seminar through our website, we will be writing to you after the seminar, and we'll also link you to the recording and tell you how you can get a copy of the presentation in PDF format as well. This is the 20th in our series of ICMDA webinars. There will be another one next week at the same time at 2 p.m. BST on a Thursday. I can't tell you at the moment what the title is because it's still being finalized, but the information will be out on our website very shortly. And we plan to keep running these seminars once a week for as long as there is interest. So thank you very much for joining us. Thank you again, Professor Bedi. Thank you so much to our translators. Thank you, Josh, on the technical side. And we look forward to seeing you next week. God bless you all.